The ultrasound-guided infraclavicular block is an upper extremity block indicated for surgical procedures involving the elbow, forearm, and hand. It can also be used to treat regional pain syndromes. The equipment required to perform the infraclavicular block includes two 20 milliliter syringes and a three-way stopcock, 40 milliliters of the local anesthetic of your choice, a 5 milliliter syringe with 25 gauge needle, 1% lidocaine, a 17 gauge TUI needle, and IV extension tubing. You will also need sterile surgical towels or fenestrated drape and a sterile prep solution, such as chlorhexidine swabs. Finally, obtain an ultrasound machine, checking to ensure that the probe and screen function correctly. A small phase array transducer is recommended for the infraclavicular block. Sterile ultrasound gel and a sterile covering will also be needed. The patient should lie in the supine position on the table with the upper extremity to be blocked, abducted at a 90-degree angle. The head should be turned away from the side to be blocked. The physician should stand on the side to be blocked, superior to the patient's clavicle. The ultrasound machine and equipment should be adjacent to the physician. Using the chlorhexidine swab, prep the infraclavicular space. Proceeding circumferentially, cleanse the clavicle, pectoral region, and inferior neck. Repeat the prep 3 times, allowing the solution to dry before inserting the needle. Sterile towels or a sterile fenestrated drape should be placed over the shoulder, pectoral muscle, and upper arm to cover the prepped area in sterile fashion. The ultrasound probe is covered with gel and placed inside the sterile covering. Hold the ultrasound probe transducer between the thumb, index finger, and middle finger in a parasagittal orientation. Lateral scanning extends to the coracoid process. Spread ultrasound gel over the patient's pectoral region. Place the probe at the inferior border of the clavicle. Scanning should proceed in the medial to lateral direction. The best ultrasound images are obtained when you apply firm downward pressure with the transducer. However, care should be taken during the infraclavicular block because excess force with the probe can cause occlusion of the subclavian vein. Scan the deltopectoral region inferior to the clavicle to obtain a transverse view of the axillary artery and vein. You can also visualize the 3 cords of the brachial plexus in this view. The Doppler mode illustrates blood flow within the vascular structures and confirms the location of the axillary artery and vein. You can also appreciate the pectoralis major and pectoralis minor muscles from this viewpoint. After the brachial plexus is well visualized on the ultrasound screen, you may choose to mark the outline of the ultrasound probe on the skin. This ensures that the probe remains optimally positioned during the block. Using the 5 milliliter syringe with 25 gauge needle, inject the 1% lidocaine into the skin approximately 1 centimeter from the probe. Raise a small cutaneous wheel. Attach the 17 gauge TUI needle without stylet to the IV extension tubing. This is connected to a 20 milliliter syringe with the stopcock. Flush the line to remove air from the system. Different needles may be used for the infraclavicular block. The 17 gauge TUI needle is recommended because it is well visualized by the ultrasound transducer. In addition, a catheter may be placed through the TUI needle to provide continuous analgesia. Insert the TUI needle through the cutaneous skin wheel. Do not advance the needle until you are able to visualize the needle tip on the ultrasound monitor. The needle is directed between the axillary artery and vein. You may perceive a popping sensation as the needle pierces through the clavicopectoral fascia. After advancing the TUI needle to the correct location between the axillary artery and vein, aspirate and give a test dose of 1 to 2 milliliters of anesthetic. If the anesthetic spreads appropriately, inject 10 milliliters around the medial cord. Partially withdraw the needle. Redirect it between the lateral cord and the superior aspect of the axillary artery. Again, aspirate and inject 1 to 2 milliliters of local anesthetic to assess the location of anesthetic spread. If correctly positioned as determined by anesthetic distribution, inject 10 milliliters of anesthetic around the lateral cord. Advance the needle to a slightly deeper position such that the tip rests posterior to the axillary artery. Aspirate the syringe and inject a test dose of 2 milliliters of anesthetic, followed by a 10 milliliter dose if the needle is accurately positioned. Withdraw the needle through the skin. Remove the ultrasound probe. The surgical team may begin to prep and position the patient for surgery. However, based on the anesthetic used, the patient may not experience the complete effect of the block for up to 25 minutes. Surgical incision should be delayed until this time has passed.